Amazing stuff. Um, as we all know, in laparoscopy today, we tout it as one of the benefits to be returning to duty faster. But returning to a desk or an office job is a lot different than to returning our soldiers and airmen and Marines and sailors to the battlefield, to a convoy, to patrols. And as Lieutenant Colonel Ritter highlighted, when you evacuate patients, it's time-consuming. It's a lot of energy and a lot of effort. So if we can avoid that, it would be good to keep our troop levels higher in theater, recovery time faster. So here to highlight that program here is Commander John Pearl, who will talk about the a system we have in Kuwait today to do just that.
Good morning. It's my pleasure today to discuss my experience that I had from my recent deployment to Kuwait. I was there from July of 2010 till March of 2011, just got home a few weeks ago. In Kuwait, most of the medical is provided by the United States Navy. Most of the troops happen to be in the United States Army. There are 5 medical facilities. The major medical facility is called Camp Arifjan, which is located here just off the Arabian Gulf. And at that facility, there's the main hospital. The other facilities are primarily provide outpatient care, and anything that's complex would go to Camp Arifjan. Kuwait's a pretty small country. To drive from Arifjan to Kuwait City looks like a long way, but that's about 45 minutes or an hour on the road. Kuwaitis drive at least 100 miles an hour, so that may be a little distorted. At Camp Arifjan, we had a fixed facility. It was constructed 3 or 4 years ago. It's a small facility that has 4 ICU beds and 20 or 22 inpatient beds. There's a strong Navy component there. At present, there are some Air Force physicians and Army physicians, but when we were there, almost all the physicians and corpsmen, nurses were the United States Navy and had been for the last 8 years or so. In Kuwait, there's no trauma. There's no battlefield trauma, that is. There's trauma from car wrecks and basic everyday trauma, but there's no battlefield trauma. So the mission of EMF Kuwait is to provide elective and emergency surgical care to anyone within Central Command area of responsibility. That can include Iraq, Afghanistan, ships at sea, Kuwait, and anywhere else in the Middle East. There are about 25,000 military personnel in Kuwait. There are at least that many contractors, some of whom we care for in Kuwait. A lot of troops transit through Kuwait on their way to Afghanistan or on their way to Iraq, and occasionally they have surgical disease or other illnesses that need to be treated. My mission, as I saw it, was to provide laparoscopic capabilities for patients in Iraq, for example, where it may not be available, patients in Kuwait, and anyone out on the ship that might need something. We were allowed to operate on someone as long as he could recover within 30 days and return to his full duty. Otherwise, he would be sent to Germany or even back to the United States. We didn't have a big surgical team there. There's 1 general surgeon, 1 orthopedic surgeon, an obstetrician, and 1 anesthesiologist, 2 nurses, and a few corpsmen. There were also 5 or 6 primary care providers there and a host of administrative staff and nursing staff. Operating rooms were fairly modern. We had everything that was necessary to perform standard operations and fairly advanced laparoscopic operations. Fully stocked with mesh, disposables, staplers, etc. The laparoscopy tower wasn't, it was sort of antiquated, but it was adequate for doing what we needed to do there. And these are just some of the equipment that we had, pretty much everything that I could ask for. So during my 7-month deployment, I did about 30 laparoscopic inguinal hernias, 14 lap choles, 17 lap appies, and some other laparoscopy. That accounted for approximately 50% of my cases. So this is about 70 cases. I did about 150 total cases there. The other ones were basic general surgery, some urology, etc. So you may ask, well, why have this facility in Kuwait? Why don't you just send patients back to Germany? There's no trauma in Kuwait. Why have 100 people there when the military medical resources are so slim? Well, the alternatives to Kuwait, I don't think, are great. If you send somebody back to Germany, even for an elective hernia repair, at least half of those patients will go back to the United States. So they're lost to the mission in the Middle East. You can medevac someone all the way back to the United States, but then again, they're lost. The patients could have an operation where they're stationed. For example, if somebody has cholecystitis while he's in Iraq, he could get, in most places, an open cholecystectomy, but that seemed pretty morbid. So oftentimes they were not equipped for laparoscopy. And in many cases, if it's an elective operation, it could be deferred until after the deployment, which probably is the best thing in most cases. I thought there were some benefits to laparoscopy in Kuwait, especially most of the benefits were realized in the hernia program that we developed. They were able to quickly recover, return to their duties, and remain in theater, which I thought was most important. One question that people often ask me is, why are you fixing hernias in Kuwait? Why don't you just wait till the patients go home? Well, it gets a little complicated. If a patient has some pain from his groin hernia, they're oftentimes disposed to return to sick call maybe every few days, every week or so, complaining of this groin pain. So that takes them out of their job, and they're still left with this lingering pain. And if we say, oh, we'll fix your hernia in 6 months or 9 months, it's often doesn't satisfy the patients. So I think it was best, in my opinion, to fix them there, get them back at work, eliminate all these sick call trips, and keep them doing their duties. So we developed a laparoscopic inguinal hernia program where I would repair symptomatic inguinal hernias. Did most of them with the TEP technique, and we developed a fast-track program for returning the patients to full duty after the operation. So you see here the timeline. For the first 2 days after the operation, patients were on convalescent leave. They'd just stay in the rack, no work for those days. I put them on narcotics and no exercise. After that, so on post-op day 3, I advised them to return to work. I may not have mentioned this, but most of the staff in Kuwait perform support roles. They do maintenance, transportation, computer work. So oftentimes they could return to work, maybe not doing anything very vigorous, but they could return, do some desk work, do computer work, do some maintenance, probably not go out on convoys yet. I'd advise them to get off the narcotics and take NSAIDs. And the Army seemed very interested in getting them back to doing their PT, but their physical training. So I did not allow them to have unit-directed PT for the first 2 weeks. But after that, back to unit-directed PT, no restrictions on their work activities, and most of the time they're off the pain medicine. So the goal was 2 days of convalescent leave, back to work on post-operative day 3, and then completely back to full duty by 2 weeks after the operation. So I looked at 23 of my patients while I was there. Most of them are young men who are thin. Almost all of them were primary hernias, unilateral hernias. My operative time was about 50 minutes. That includes one that took me an eternity. And most of my patients were able to return to work on post-op day 3, 21 out of 23 patients. So the two patients that did not return to work both had recurrent hernias. One guy had a twice recurrent hernia, including one anterior repair and a previous TEP that I did a tap on. It took me a long time to do. and he had a lot of pain, so he couldn't return to work on post-op day 3. Another patient had a large recurrent hernia. He had a previous anterior repair. I did a TEP on him, and I got a little bit lost and dug into his psoas muscle and dinged up his lateral femorocutaneous nerve. So he had some paresthesias after the operation, which resolved after about a week or so. So he was not able to return to work on post-op day 3. But 21 of the 23 patients were able to return to work on post-op day 3 and adhere to the protocol with the narcotics and the exercise program. So how come that protocol was successful? These are mainly young, thin, healthy patients who are in pretty decent shape. Many of them are motivated to get back to work, and most of them are not out. Most of them are not infantrymen, or they're not doing very vigorous activity compared to a maintenance guy, a transportation guy, compared to an infantryman. It's different duties. So I concluded that it was probably for unilateral primary repair, you could get patients back to work on post-op day 3 or 4. But at least in my case, the recurrent repairs, it was hard to get them back to work so rapidly. So I concluded that the benefits of laparoscopy in Kuwait were surgeon dependent. It happens to be that when I left in March, I was replaced by a cardiac surgeon, so he probably won't be doing too many lap inguinal hernias. He can do a cardiac bypass, though, I guess. We had a successful hernia program there. It saved a lot of guys from going back to the States or going back to Germany, being lost and needing to be replaced. I didn't talk too much about it, but the lap API, lap chole data, it was helpful because we could get those guys back to work in no time. It was a benefit for the entire theater. And laparoscopy, I thought, provided a useful support role for OEF and OND. Operation New Dawn is the new Operation Iraqi Freedom. Well, thank you very much today. I enjoyed talking to you.